Good morning and Assalamualaikum to all. Okay, today we are very lucky because we're going to have a presentation from Prof. Rina, Microbiology Department. Okay, I'm Dr. Nuriana, moderator for today, the first session of morning breakfast talk. Okay, without further delay, I would like to invite Prof. Rina to give her talk on the title of a case report of identification of a rare organism from a patient with prosthetic joint infection. Without further delay, I would like to invite Prof. Rina to give her presentation.
Good morning, everyone. The case report, wait, hang on, let me just share my screen. Good morning, everyone. The case report that I'm about to present has just been published in the International Journal of Infectious Diseases. And I would first like to quickly acknowledge all my co-authors, basically Professor Azahar and Dr. Hairul Anwar Ayub, who were the orthopedic surgeons who managed this patient and gave us the clinical history for this presentation. Dr. Kartini Abdul Jabbar, Associate Prof. Rukumani Velayudan, who together with myself reported on the microbiology reports for this patient on 3 separate occasions. Professor Te Santi, who helped us to confirm the molecular identification using whole genome sequencing of this rare organism. And my technicians from the Department of Medical Microbiology, UMMC, Ms. Lee Jiangling, as well as Ms. Jennifer Chong. So without further delay, let me begin. My name is Rina Karunakaran, and basically my presentation today is on this rare bacterium. So a rare gram-positive bacillus was isolated on 3 occasions over 8 months from clinical specimens taken from the right knee for osteoarthritis. Those of us who are not orthopedic surgeons, periprosthetic joint infection is infection involving the joint prostheses and adjacent tissue, and it's actually a serious complication of prosthetic joint implantation. It almost always requires surgical intervention and prolonged courses of antimicrobial therapy. And as for the definition, actually, there is no single definition that has gained acceptance as a reference standard for clinical practice. And this may be due to many factors, including the complexity of the infection, geographical variations in practice, the use of expensive tests, and disagreement over the accuracy of some of the included tests. So, as I mentioned, there's no reference standard definition. And the first one, convened by the Musculoskeletal Infection Society, MSIS, in 2011, was probably the first attempt to come up with a proper definition. And this was followed by the International Consensus on Musculoskeletal Infection. They met and they tweaked the original 2011 definition a bit in 2013. And then there was the IDSA guidelines by Osmond et al. In 2013. And looks like the orthopedic community has been very busy trying to figure out the best definition, because there's another one in 2018, the definition of periprosthetic hip and knee infection and evidence-based and validated criteria, which I understand from Dr. Khairul is the one that is being used by the Division of Joint Reconstruction of UMMC. And then finally, I've also seen another one, the European Bone and Joint Infection Society definition, which is published in 2021. So if you look at the very first definition, just to give you an idea of what it's about, definitive prosthetic joint infection exists when either there is a sinus tract communicating with the prosthesis, or a pathogen is isolated by culture from 2 or more separate tissue or fluid samples obtained from the affected prosthetic joint. Then you need at least, if you don't have that, then you can have 4 of the following 6 criteria. And one of the criteria here is isolation of a microorganism in just one culture of periprosthetic tissue or fluid, among the other criteria that you can see here. Right, so as you can see, well, actually the authors also said that PJI may be present if there are fewer than 4 criteria as well. So looking at the earlier definitions, you can see that a sinus tract communicating with the prostheses, as well as identical microorganism isolated from 2 or more cultures, are actually part of the definitive evidence of prosthetic joint infection in both the, in the MSIS definition, in the International Consensus definition, as well as the IDSA guidelines of 2013. So Now I'm just showing you briefly the table from Parvizi et al., the 2018 periprosthetic joint infection definition, which is the one that's being used in the Division of Joint Reconstruction in UMMC. So it's got the same major criteria. And you can see that apart from that, they've got two extra criteria here, which is the D-dimer test, which is also part of the minor criteria, and also a positive alpha defensive test, defensin test. So all the criteria can be scored, and they are pre-operative diagnostic criteria as well as post-operative diagnostic criteria, which can be used. And you come up with a score. And if the score is 6 and above, then it's infected. And if it's 4 or 5, it's inconclusive. And the authors have said that you could consider further molecular diagnostics such as next generation sequencing in these kind of cases. So let me move on now to the case report. The patient was a 60-year-old gentleman with end-stage renal failure for more than 10 years and on renal replacement therapy, who had, in 2018, underwent sequential total knee replacement for severe osteoarthritis. So the right knee was done in April and the left knee in August, and he had standard pre-op prophylaxis with intravenous cefazolin. And during the index surgery of the right knee, he was admitted to the ICU for hemodialysis. Subsequently, in March 2019, which was 11 months after the right total knee replacement, he had anterior knee pain with poor patellar tracking, which the orthopedic surgeons performed a secondary resurfacing procedure of the right patella. At that time, they did not suspect any infection. There was no signs of loosening. And a synovial fluid specimen, which was a bloody tap actually, was sent for culture in BACTEC blood culture bottles. And a gram-positive Coccobacillary bacterium was cultured from the aerobic bottle only. The isolate was initially assumed to be a contaminant as there was only one positive sample and the organism was atypical. It couldn't be identified easily, and it was just a gram-positive rod in one sample. And since clinically the patient was not suspected as infection, it was thought to be a contaminant at that time. However, the patient's knee pain persisted, and radiographs obtained about 3 months later showed signs of tibial component loosening, and the doctors performed another arthrocentesis and again sent us the synovial fluid in the BACT alert blood culture bottles. And the same gram-positive rod was isolated again from the aerobic bottle only. So at this point, we've got the organism isolated twice. And to tell you the further characteristics of this organism, I'd like to invite you into our Department of Medical Microbiology in University Malaya Medical Center. So please come with me. This is our department, the specimen reception counter, and this is the doors. As you can see, it says restricted area and authorized personnel only, but I'm taking you in with me today. Please come in. This is the diagnostic bacteriology unit of the diagnostic lab. And again, it's a restricted area. And guess what? I'm taking you in with me to have a look at the culture plates. So this is the culture plate of the organism. So basically, it's not very outstanding. It was just creamy, whitey colonies ranging from 1 to 2 millimeters in diameter. And on microscopic examination, the organism appeared as Coccobacilli. So in some areas, it looks like rods, and in some areas, it looks like cocci, which makes it a Coccobacilli. So if you remember some of your microbiology that you learned way back in your medical school days, this organism didn't grow on McConkey agar, and it was non-motile, and it was catalase positive. So we put it through our normal identification processes at that time in 2019, which was the API Coraini test, which identified it as Brevibacterium species or Arthrobacter species with low discrimination. So we didn't accept this identification. And just to show you what an API Coraini test kit looks like, it's miniaturized commercial biochemical test, and it uses software for analysis of the results, but it didn't fit and we didn't accept that identification. We went on to the next tool that we had at that time, which was the YTAC2 ANC card. The YTAC2 is an automated identification and sensitivity testing system. And it does the automated biochemical test, reads it, analyzes it, and it came up with the identification as Propionibacterium acne with an accuracy of 93%. Now, again, we didn't accept this identification because the organism that we had isolated was an aerobic organism, whereas Propionibacterium acne, or Cutibacterium acne, as it's now known as Cutibacterium acne, is actually an anaerobic organism which grows best in anaerobic conditions, and our organism didn't grow in anaerobic conditions. So this is one of the challenges that a clinical microbiologist faces. We may have all kinds of tools and automated devices, etc., but whatever identification we get, we've always got to correlate it with the phenotypic characteristics of the organism that we've grown and decide whether we can accept the identification, because occasionally when the organism is very rare or difficult to differentiate with what's in the database of the system, you can get misidentifications as well. So we then went on to the next tool. And in 2019, we had just started using mass spectrometry, the metric-assisted laser desorption ionization time of flight technology for identification. And this is actually a very good system. And that's what we use nowadays. But unfortunately, it couldn't identify this organism because this organism is so rare and there was an absence of a matching spectral profile in its database. So that left us with the next tool that we have, which is molecular identification by the 16S RNA-PCR and sequencing. So the best identification match when we did it with the 750 base pair target was false Arthrobacter nasifocae. Wow. This was an organism that we'd never heard of before. And so we did a quick literature search, which told us that previously, this organism was only described from the nasal swabs of two common seals known as Phoca vitulina. And this report came from Collins et al. In 2002, and it was from the University of Reading and published in the International Journal of Systemic and Evolutionary Microbiology. And subsequently, Arthrobacter nasifocae was then reclassified as false Arthrobacter nasifocae, because this organism was found to have a distinct peptidoglycan type and quinone system, and it was phylogenetically distantly related to the type species of the genus Arthrobacter based on 16S RNA-DNA sequencing. So basically, this was reported in 2018 in International Journal of Systemic and Evolutionary Microbiology by Buse and Moore. And so that's what we had, false Arthrobacter nasifocae. So the identification that we got, however, we took it as a preliminary identification because the score was only 97.74%. And we correlated this to our orthopedic surgeons and asked them whether the patient had any exposure to seals or any history of travel. So apparently the patient didn't have such history. And moving on, meanwhile, what we had now was having isolated the same organism twice, and the organism had the same characteristics, and clinically too, the clinicians thought that the patient had prosthetic joint infection. It now fulfilled the definition of PJI as well, and the patient was now planned for removal of his prostheses. In microbiology department, meanwhile, us clinical microbiologists plan to confirm the identification further using a longer 16S primer base pair, 1,500 base pairs, and antimicrobial susceptibility testing was performed using the e-test and interpreted using the Corynebacterium and other related genera based on the Clinical and Laboratory Standards Institute's guideline. And we had to use these because there is no obviously, there is none specifically for false Arthrobacter. So we used the nearest one that we could get to give some idea of sensitivity. And so based on this, vancomycin was susceptible, but the isolate was intermediate to penicillin and ciprofloxacin. When we'd done our 1,500 base pair 16S, we then consulted our scientist colleague in Department of Medical Microbiology Department, none other than Professor Tay Santi, and we needed her help to help us to analyze the results that we got and to help us confirm whether this really was false Arthrobacter nasifocae or not. So she actually looked at the results as well and constructed a phylogenetic tree using the MEGA software and found that with her analysis, the highest sequence match was with false Arthrobacter nasifocae at 98.1%, and with the phylogenetic tree, it confirmed the placement in the same branch as false Arthrobacter nasifocae with a 99% bootstrap confidence level. And she also subsequently went on to do whole genome sequencing to confirm the identification, which again confirmed that the organism was false Arthrobacter nasifocae. So what happened next is the patient underwent right knee implant removal and fusion using an external fixation in October 2019. And cultures from that surgery were sent to microbiology again. And once again, we grew false Arthrobacter nasifocae from the synovial fluid sent in blood culture bottles, from the femoral intramedullary tissue, which also grew 3 other organisms, which were Cocuria christini, Neisseria species, and Streptococcus sanguinis. Now, Cocuria christini can be also part of normal flora, can cause opportunistic infections as well. Neisseria species that we identified, my esteemed audience, is not Neisseria gonorrhea or Neisseria meningitidis, but it's just the other Neisseria species, the commensal ones, which can sometimes be normal flora as well, and Streptococcus sanguinis, which is a viridans streptococci, which is found in the oral cavity of people. So this is what also grew from the femoral intramedullary tissue. Meanwhile, tissue from the right knee joint actually grew Staphylococcus hominis, which is a coagulase negative staphylococcus from enrichment culture only, while intramedullary tibial tissue had no growth. And my colleague who was reporting on this did an extensive antibiotic sensitivity testing because there is no susceptibility testing reported in the literature for false Arthrobacter nasifocae. And based on the presumptive interpretation that we took, it was not only sensitive to vancomycin, but also susceptible to linezolid, trimethoprim sulfamethoxazole, doxycycline, and intermediate to penicillin and ciprofloxacin, and resistant to ceftriaxone. So most unfortunately, during the admission, the patient could not recover from his post-operative stress. He had renal failure and was in hemodialysis as well, and he succumbed to his illness. He passed away approximately 3 weeks after the surgery. So if you look at the timeline of the organisms and what we isolated, you can see that false Arthrobacter nasifocae was isolated on 3 occasions from several samples, whereas Cocuria christini, Neisseria species, and the other organisms that we isolated were only identified once from 1 specimen each. So it's not possible for us to determine if the other organisms isolated from the specimens at that last surgery were truly pathogens or contaminants. They may well have been true pathogens too, but it's really not possible for us to determine this with certainty. But we do know that the false Arthrobacter nasifocae, which was isolated on 3 occasions, was significant because it was persistently there, and it shows that it has the ability to persist and survive host defense at the site of prostatic joint infection, where organisms can strive within biofilms and impede penetration of antibiotics. The disease potential of this organism in animals and humans have not yet been reported, which makes this our first clinical case report reported with false Arthrobacter nasifocae from prostatic joint infection. So on further reading, this common seal, is also known as the harbor seal, is actually a true seal found along the temperate and Arctic marine coastlines of the Northern Hemisphere. So I am sure that you must be wondering right now, as how we wondered at that time as well, how did this bacteria reach the knee of this patient and cause prostatic joint infection? So in the pathogenesis of PJI, organisms can actually be introduced at the time of surgery, or it could be due to contiguous spread of infection from adjacent sites, or it can be due to hematogenous seeding. However, biofilms are also very important in prostatic joint infection because organisms can then be protected from antimicrobials and the host immune system, and treatment without surgical intervention is usually difficult with biofilm organisms. It also makes it difficult to identify the organisms from cultures because they may not grow very well. So again, how did this organism get to the patient's joint? Well, to tell you the truth, actually, it's not certain to us either. It's likely that the organism may have developed on the knee implant for some time prior to its isolation, maybe during the immediate post-op period, or maybe during the hemodialysis session in ICU post-operatively. We can only hypothesize because we can't be sure. And it's not surprising that initially it was thought to be a contaminant, because PJIs can be quite indolent during early infection. But when the infection spreads to the interface between the implant and the bone, it may cause loosening of the implant and cause further problems to the patient. So the source in this case remains elusive. And we really don't know why this rare organism was isolated from this patient instead of the usual organisms which are isolated from PJIs. So if I talk about usual organisms, then I've got to tell you, right, what are the usual organisms isolated from prosthetic joint infections. So looking at this table from Tande et al. Published in Clinical Microbiology Reviews, you can see that they've done a review with so many joints and joint infections, and all time periods for hip and knee. You can see that Staph aureus and Coagulase negative staph are the #1 culprit organisms causing periprosthetic joint infection. And this is followed by polymicrobial cases, culture negative cases. Sometimes you can get gram-negative organisms, some Streps and Enterococcus, as well as sometimes anaerobic bacteria. And in early infection, although Staph aureus is still the #1 cause in the series, but polymicrobial cases are also pretty important, and also aerobic gram-negative organisms in early infection. And this is followed by the other organisms, and certainly Coagulase negative staph is also pretty important. And specifically for knee periprosthetic joint infection, again, Staph aureus is very, very important, and so is Coagulase negative staph, followed by other organisms. And I just like to highlight here that for shoulder arthroplasty infections, as you can see here, although Coagulase negative staph is very important, Propionibacterium acne, which is also known as Cutibacterium acne right now, is extremely important in shoulder arthroplasty infections, but not so much so in the other joints. Okay, so the proportion of organisms isolated may also be different according to different series. So in this recent one, published in Antibiotics Basal in 2022, in this series from Germany, Coagulase negative staph were actually accounting for 44% of the cases of prosthetic knee and hip joint infections, followed by Staph aureus, and followed by gram-negative organisms and the other common organisms. And how about Malaysian data? Do we also isolate the same kind of organisms? Well, there is a publication by Muhammad Iqbal et al. In the Malaysian Orthopedic Journal, which they presented at a scientific meeting in Kuala Lumpur in 2019. And this report is actually from HUKM. And they did a retrospective study over 10 years involving 990 patients. And they only found 13 infected patients with PJI. And the commonest organism was Staph aureus methicillin sensitive, followed by MRSA. And they had some gram-negs and other organisms as well. And another publication during the COVID-19 outbreak by Anwar Ali Khan et al., published from Hospital Kuala Lumpur, published in the journal Curious, reviewed cases that were managed with PJI during the pandemic, and they had 11 cases. And again, the most commonest organisms were Staph aureus and Coagulase negative staphylococci, and one patient each of the other following organisms. So as you can see, in Malaysia too, the common organisms which cause PJI are found in literature from other parts of the world. So what are the unusual organisms then? Have other people reported unusual organisms? So a quick literature search, we found a publication by Anagnosticus et al. They did a study and they found that some of the rare organisms they found accounted for about 9.7% of all PJIs, and this study was in Germany. And I've highlighted the organisms in blue as, those are the strict anaerobic organisms: Veillonella, Parvimonas micra, Clostridium difficile, and Fine Goldia magna. And among the other rare organisms that they got, which are not usually commonly isolated as part of the usual gram-negative organisms that are encountered from PJIs, were like Pastorella, Panthera, Citrobacter costorii, Serratia marcescens, Morganella morgani, as well as yeast. So in summary, For this case, the use of emerging technologies has shown to be able to help to confirm identification of rare organisms, without which atypical organisms such as false Arthrobacter nasifocae may go undetected, leading to underreporting of its actual incidence. So basically, I would also like to briefly highlight also to you some important areas in medical microbiology in relation to the diagnostics in prosthetic joint infection. The optimum duration of culture incubation is quite controversial, and some studies have said, some guidelines say that you should incubate cultures for a minimum of 5 days and up to 14 days. Some of them suggest even longer durations. Some may suggest shorter durations if you use special culture techniques. And in UMMC microbiology, we don't actually use prolonged incubation. We use the standard incubation for all our cultures together with an enrichment broth. However, if we get a special request from the orthopedic surgeons that they haven't grown anything, but they're really thinking of infection and they want us to extend the incubation, then we extend the incubation for them. And we don't do this routinely otherwise, because we are worried about contamination of the plates the longer we keep the incubation period. Sonication technique has also been mentioned in many publications as a technique to improve the yield. Again, we don't do this technique in the UMMC because, again, it needs some specialized equipment, and also you have to be very careful when doing this technique. Otherwise, you can introduce contamination. However, these techniques can actually be tried out if you do an evaluation study and with the orthopedic side and show that it is of benefit. So there are also some studies in the literature which have shown new methods of processing periprosthetic tissue. Peel et al. Have published about improving diagnostics using, they process the tissue and put it into blood culture bottles, and they've shown better yield from that. So these are all some of the newer studies which have shown that they can help with making it easier to identify organisms, and research is ongoing in these areas. And the future role of molecular diagnostics and next generation sequencing, well, actually, this guideline has said that molecular techniques are gaining momentum and they promise to be useful, especially for culture negative cases, but lack clear interpretive criteria for whole genome sequencing at this point. And that makes it difficult to include them in a definition set at this point. And low-grade infections can be missed, and overdiagnosis is a risk with false positive results. And a PJI definition must recognize limitation of existing tests and the need to interpret in the clinical context. So PCR, it has shown promise because it's fast, sensitive, and works even with previous antimicrobials. But I have to caution you that there are limitations too. You can have risk of contamination, restricted identification if you're using multiplex panels, and they only identify certain organisms, or if the organism only makes up a certain proportion of DNA within a mixed population. For next generation sequencing, Khuen and Parvizi have reported in expert reviews of molecular diagnostics that it's likely to have a very important role in the future. But currently, there are still some difficulties in identifying potential pathogen or combination of pathogens, not knowing if it is active or whether it's a contaminant, the nature of, the clinical relevance, the possibility of is there, could there be a microbiome, etc., in the knee? So there are lots of unanswered questions, and further multi-center work is required to translate experimental technology into clinical practice. So I leave you now with the wise words of Parvizi et al. From Journal of Arthroplasty. Clinical judgment should still prevail and guide physicians in the management of patients. And there may be situations when a patient is infected and does not meet the diagnostic criteria, and vice versa. So I think my time is run out. And so I think I've got to stop here. I thank you very much for listening to me. And once again, I would like to acknowledge my co-authors for this paper, who I've already acknowledged in the beginning, but acknowledge them again, as well as the Department of Medical Microbiology, the funding sources that Prof. Te Santi used, and thank you, the audience, again for listening.
Thank you, Profina. Okay, so we have another, we're almost finished, but let's see if there are any questions. Okay, we have one question. Good morning, Dr. Yana and Profina. Two questions actually. How was the subsequent identification of the organism performed? from intraoperative tissue, 16S RNA used as method of identification, and what was the prescribed antimicrobial to this patient?
Okay, for the first question, the organism was isolated using a routine culture from the intraoperative tissue and also from synovial fluid. And I think I mentioned that in my earlier slide. And we confirmed the identification again using 16S RNA and compared it. It had the same 16S sequence as the earlier ones that we had confirmed. We did whole genome sequencing. Prof. Tay did the whole genome sequencing on one of them, and the 16S profiles of all the times that we isolated the organism were identical. And for the antibiotics, actually, I'm not sure what was used at that point. I think they used broad spectrum antibiotics, including vancomycin. And, unfortunately, the patient passed away. And
okay, I think time's up already, and we don't have any further question. Thank you very much, Prof. Rina. And I will pass the station to the next moderator. Thank you very much.